This video describes the technique of endoscopic tympanoplasty with a panoramic view of middle ear. 25 years old lady diagnosed as a case of severe mucosal inactive right side with a small perforation in the anterior-inferior quadrant and a mild conductive hearing loss on PTA. Autoendoscopy, we can see the small perforation. Then you freshen the margins of the perforation using a needle. You will be able to see the edges of perforation very clearly. Then you score using a round knife. Then you give a curvilinear incision from 1 o'clock to 5 o'clock. The incision is deepened till the underlying bone. Then you raise the tympanomeatal flap using a round knife. You can see the annulus, and you have to raise the flap from the tympanic sulcus. The flap is further elevated for a better exposure. And now we do the inspection of middle ear. You can see the handle of malleus, the pyramid, the processus cochleoformis and the tensor tympanic canal, the round window, the fustus, you can see, which helps in identifying the round window, promontory, the tympanic plexus, the Jacobson's nerve, which is a branch of 9 cranial nerve, and the hypotympanic air cells, and the funiculus, which separates subtympanic sinus and hypotympanum. The stapedial tendon can be seen, the long process of ingus, the head of stapes, and superiorly you will be able to see the anterior epitympanum. Anteriorly you can see the eustachian tube marked as yellow and tensor tympani marked as red. You will be able to see the facial nerve above the stapes footplate and the lateral semicircular canal over it. In the retrotympanum, you can see the sinus tympani bounded by bony ridges, pondicular superiorly and subiculum inferiorly. Next, you test the mobility of ossicles and you have ensured the middle ear is free of disease. Then you deskeletonize the handle of malleus for insertion of graft. Now the harvested temporalis fascia graft is inserted. And you can see the underlay technique being done. The proper positioning of graft is done. Then you raise the flap and graft together. Middle ear is packed with gel form. Then the flap is repositioned and the graft is adjusted to cover the perforation. You can see the perforation well covered with the graft. EAC is then packed with gel foam and bib soaked ribbon gauze. The advantages of endoscopic tympanoplasty include small incision, minimal excess surgery, ability to look around the corners, shorter operation time, reduced post-operative mobility and early recovery. However, one needs to develop the skills for performing an endoscopic ear surgery.